In video number 1 of our diabetes series, we learned all about the clinical presentation and diagnosis of type 1 and type 2 diabetes. Now it's time to scooch in a little closer, kids. That's it. Scoochy, scoochy. Don't be shy. This is the story of Longer Hansel and Gretel, Chapter 2, The Management of Diabetes Mellitus. To start off, let's recap with a summary of the story so far. Willie B. is a 55-year-old obese man with hyperlipidemia presenting with blurred vision, increased thirst, and frequent urination for 6 months. He works as an office clerk, does not exercise, and consumes fast food, sodas, and sweets regularly. His vitals are significant for a blood pressure of 155/92 and a body mass index of 36. On general examination, he's obese and there is hyperpigmentation of the neck and axilla. Labs are significant for a hemoglobin A1C of 9.8% and a fasting blood sugar of 205. The cause of this patient's symptoms is most likely untreated type 2 diabetes. As we discussed previously, patients with type 1 diabetes do not produce insulin. Therefore, insulin therapy is the cornerstone of management for those patients. Meanwhile, type 2 diabetes initially starts with insulin resistance, which over time can lead to beta cell burnout and a need for insulin. However, prior to that point, there are lots of other ways we can manage diabetes without insulin, which we'll discuss in a bit. To make sure that the therapy is effective, glycemic control should be monitored regularly.
Diabetes.
Wilfred, would you cut it out? This isn't a Liberty test supply commercial. Anyway, hemoglobin A1C reflects average plasma glucose over approximately 3 months and has strong predictive value for diabetes complications. A1C is symbolized here by this seasonal candy. A season being 3 months, of course. The A1C should be measured every 3 months in patients who have not reached their goal range and require adjustment of therapy. This can later be spaced out to every 6 months in patients with stable control who are meeting treatment goals. The goal of A1C for most adults is less than 7%. Hence the 7 we've incorporated into this toy car in the back. This applies to patients with type 1 or type 2 diabetes. Though the evidence is not as well established, a more stringent goal of less than 6.5% might be recommended in certain patients. These include patients who have not had diabetes for very long, type 2 diabetes treated with lifestyle modification or metformin only, those with a long life expectancy, and no significant cardiovascular disease. Young, relatively healthy patients, in other words. Embodied by this young candy enthusiast. To achieve this goal, more intensive therapy may be required. So, obviously, it's not the kind of regimen for a patient prone to developing hypoglycemia. Intensive therapy has been clearly shown to reduce microvascular complications of diabetes, including retinopathy, neuropathy, and nephropathy, which is why he's chewing on the small diameter end of this vascular candy snake. Data is less clear when it comes to macrovascular complications, however. Intensive glycemic control may reduce the risk of cardiovascular events and mortality in type 1 diabetics and newly diagnosed type 2. However, most randomized controlled studies have failed to demonstrate a benefit for long-standing type 2 diabetes. Ultimately, the best way to prevent macrovascular complications is by treating the whole patient. So, not just focusing on glycemic control, but also addressing smoking cessation, blood pressure management, lowering cholesterol, and, in many cases, helping the patient lose weight. A less stringent goal of less than 8% is reasonable for patients with a history of severe hypoglycemia, limited life expectancy, advanced microvascular or macrovascular complications, extensive comorbid conditions, or long-standing diabetes in whom the goal is difficult to achieve. So, in the back, behind the number 8 themed wagon, we've drawn in an old forest witch riddled with stale candies, evoking the idea of an older patient with shorter life expectancy and extensive disease, as well as an extensive hunger for something besides candy. Something more fleshy and young. Now that we've covered some of our goals, let's talk about how we can achieve them, starting with insulin. Insulin is typically administered as multiple daily injections to stimulate the normal physiologic secretion of insulin in response to a glucose load. When starting a patient on a daily insulin regimen, such as a patient with gestational diabetes or newly diagnosed type 1 diabetes, A weight based calculation is used to estimate the total daily dose. A new type 1 diabetic is typically started on zero point 0.2 to zero point 0.4 units per kilogram per day. Instead of memorizing numbers, just remember that this is a weight based calculation, highlighted here as we calculate the weight of this candy labeled inside. We use the word inside to symbolize insulin, not only because of the awkward slant rhyme, but also because insulin is the major anabolic hormone of the body, bringing nutrients inside cells for use and storage. Once you've estimated the total daily dose, divide it by 2. Half of the insulin will be long acting, aka basal insulin, represented by the long lasting jawbreaker in the base of the egg. There are a few options for basal insulin. Most commonly, long lasting insulin's glargine or detamere are used, and they're administered once or twice per day. Another option is degludec, a very long acting basal insulin that's administered only once daily. A third option for basal insulin is NPH, symbolized by this nutty peanut and hazelnut bar. NPH is an intermediate acting insulin, dosed using a 2/3, 1/3 rule. That means that 2/3 of the basal dose is given in the morning, and the remaining 1/3 is given in the evening, which is exactly how we've split up this nutty peanut bar. Alright, that's the basal half. What about the other 50% of the insulin we calculated for that total daily dose? Well, this is going to be our short acting insulin, also called bolus or preprandial insulin, as depicted by the prandial birds nibbling on the short acting candies. Typically, a rapid acting insulin, such as Lispro, Aspart, or Glulicine, is used before meals. In some cases, regular insulin may be used. These agents cover the glucose spikes that occur after eating. As an alternative to multiple daily injections, some type 1 diabetics are managed with an insulin pump, which employs a continuous infusion of rapid acting insulin, such as Aspart, Lispro, or Glulicine. Approximately 50% of the total daily dose is administered at a basal rate. The other 50% is spread out across preprandial doses. So think of it as being pretty similar to the 50-50 rule we used for our weight-based calculation, just with short-acting insulin only. Just a quick word about mixed insulins, since you'll likely encounter these formulations in the clinic and on patient charts. Pre-mixed insulins include Humalog Mix 7525 and Novolin 7030. Don't get confused about the name and instead read the ingredients. That fraction written on the side is telling you what percentage of insulins are mixed together. Usually a rapid acting insulin with a more intermediate acting insulin like NPH. The injection is usually intended to be given in the morning and evening before meals. The upside to mixed insulins? More convenient dosing for patients. The downside? It's harder to make adjustments to the regimen because the short acting and basal insulins are dosed together. Optimal glucose control is achieved with careful titration of basal and prandial insulin separately. Now let's go over the management of type 2 diabetes. Type 2 diabetics are often overweight or obese. In these patients, management should always begin with lifestyle interventions such as diet, exercise, and weight loss. However, in many cases, pharmacotherapy is initiated in addition to these lifestyle changes. Metformin is the preferred initial pharmacologic agent for the treatment of type 2 diabetes and should be initiated at the time of diagnosis for most patients along with lifestyle interventions. At Sketchy, our recurring symbol for metformin is a metaphor, of course. Like this one here greeting the passersby. The chewy caramel center of life. Ah, that's fun. As you might recall, metformin is an oral anti-diabetic agent that acts in the liver to inhibit gluconeogenesis and results in increased insulin sensitivity. Metformin can also decrease the hemoglobin A1C by about 1 to 2%. So, up on the main entrance of the A1C gingerbread house, we've drawn 2 down arrows. 2 for 2%. In addition, metformin has been shown to reduce the risk of cardiovascular disease. Metformin has the additional advantage of not causing hypoglycemia. In this scene, we're going to convey the idea of hypoglycemia with the sugary mints falling from the trees of the candy forest. Medications not associated with hypoglycemia will be illustrated underneath the trees that are not dropping their candy. This includes metformin. Metformin has another benefit. In obese patients, it can promote weight loss, or at least weight stabilization. So we've made this kid here, lured by the metaphor, well, thin, to say the least. definitely not the plump specimen these witches are looking for, which is why they've set out some food for him. The most common side effects of metformin are GI upset, such as nausea and diarrhea. Slow down there, Hansel. A few other side effects to keep in mind. First of all, metformin can lead to lactic acidosis. See this spoiled milk here being spilled by our metformin muncher? It's our recurring sketchy symbol for lactic acidosis. It turns out that when you inhibit hepatic gluconeogenesis, you also restrict lactate's ability to enter gluconeogenic pathways in the liver. So it builds up in the blood instead. Now, this is an extremely rare effect. Just throwing that out there. Like, extremely rare. But lactic acidosis can be fatal and is more likely to occur in the setting of renal failure when there's decreased clearance of metformin. As a result, metformin is usually held in patients with renal impairment, specifically a GFR less than 30. Metformin is also contraindicated in patients with other factors predisposing to lactic acidosis, including alcohol abuse, liver disease, and states of decreased tissue perfusion such as sepsis. Vitamin B12 levels should be monitored in patients on metformin because long term use can cause vitamin B12 deficiency. Since vitamin B12 is also called cobalamin, we'll illustrate deficiency with an empty pack of cobalt blue poppers. Whoa, looks like these kids aren't the first visitors to this creepy cottage. This send help message, along with the number 3 we've included in there, should remind you that another drug is added to metformin if the A1C target is not achieved after 3 months. Not only that, if dual therapy fails to achieve the A1C goal after yet another 3 months, you can add a third agent. There are many different classes of medications that we can use in addition to metformin. The preferred treatment options include sulfonylureas, thiazolidinediones, DPP4 inhibitors, SGLT2 inhibitors, GLP-1 receptor agonists, and, well, there's always insulin. In general, these should be added to metformin. However, in patients whom metformin is contraindicated or not tolerated, one of these agents can be used instead. Also, some clinicians will begin immediately with dual therapy if patients present with an A1C greater than 9. Most of these additional drug classes, when added to a metformin regimen, will decrease A1C by an additional 0.7 to 1%. We'll place these other drug classes around the smaller side door of the A1C cottage with the single down arrow. 2 exceptions to this are insulin and sulfonylureas, which lower the A1C comparably to metformin, or even more. We'll start off with sulfonylureas, which are symbolized by these stinky sulfa eggs next to Mother Goose and her goslings. Specifically, we're talking about second-generation sulfonylureas, as first-generation are no longer used. The drugs in this class include the short-acting agent glipizide, represented by the zigzagging gosling, as well as the longer-acting agents glimepiride and gliburide, embodied by the goslings riding, if you will, on their mother's back. Additionally, Mother Goose's long neck emphasizes the long-acting nature of glimepiride and gliburide. The sulfonylureas are oral agents that are both inexpensive and rapidly effective. They work by stimulating insulin secretion, so they're only useful in patients with some beta cell function. Similar to metformin, sulfonylureas can decrease the hemoglobin A1C by about 1 to 2%, which is why we've placed Mother Goose next to those 2 down arrows on the A1C house. Adverse effects of sulfonylureas include weight gain as well as hypoglycemia, symbolized here by the portly hag enjoying some falling forest candies. A short-acting sulfonylurea, such as glipizide, is less likely to cause hypoglycemia than the longer-acting agents, such as glimepiride and gliburide, sitting on the back of Mother Goose over there. So, we've made a falling candy smacking Mother Goose in the head. The thiazolidinediones, or TZDs, are another class of diabetes medications that increase insulin sensitivity by acting on adipose tissue, muscle, and the liver to increase glucose utilization and decrease glucose production. Just think of these thiazolidinedione dandelions. Pioglitazone is the agent of choice from this class. It's symbolized by the pioglitazone glitter, luring unsuspecting children to a premature, chewy, and somewhat nougaty demise. The use of rosiglitazone is not recommended because of its associated increased risk for cardiovascular events. TZDs do not cause hypoglycemia, which is why the trees aren't dropping candy on this side of the sketch. They do cause weight gain, though, hence this kid's portly figure. Looks delectable. In addition, TZDs cause fluid retention, so they're contraindicated in NIHA class 3 or 4 heart failure. They can also cause bone fractures, especially in women, and are generally avoided in patients with low bone density or other risk factors for fracture. Next up, the gliflozins, such as empagliflozin, canagliflozin, and dapagliflozin, embodied by this flossin forest hag. Bit of a Gretel caught in her teeth, it seems. Wait, never mind. I guess the children harvest has been a bit slow this year, and she's been satiating herself with that salty glucose kettle corn. Let it remind you that empagliflozin is a sodium glucose cotransporter 2, or SGLT2, inhibitor. SGLT2 is normally responsible for glucose reabsorption in the proximal tubule. So, as you can imagine, if we inhibit SGLT2, then glucose gets excreted in the urine. Other benefits of SGLT2 inhibitors include weight loss, which is why this flossin' hag is looking pretty gaunt. SGLT2 inhibitors have a low risk of hypoglycemia, so again, notice that the trees in the back are not dropping their candy. Adverse effects include genitourinary infections such as vulvovaginal candidiasis and UTIs, symbolized here by the urinary tract looking glass. There are a few other empty glasses here as well, emphasizing the volume depletion that occurs due to osmotic diuresis as all that glucose is dumped into the urine. This can lead to hypotension. Next up, the injectable glucagon-like peptide 1, or GLP-1, receptor agonists, symbolized by this audible gulp as our next witch notices the visitors. GLP-1 receptor agonists, such as exenatide and liraglutide, improve glucose control through several mechanisms, including enhancement of glucose-dependent insulin secretion, slowed gastric emptying, and reduction of postprandial glucagon and food intake. Other benefits of GLP-1 receptor agonists include weight loss, emphasized by the witch's overall emaciated constitution, and they're not likely to cause hypoglycemia. Common adverse effects include GI upset, like nausea, vomiting, and diarrhea. There may be an association with acute pancreatitis as well, and are usually avoided in patients with a history of pancreatitis. According to the 2018 ADA guidelines, if you're treating a patient with atherosclerotic cardiovascular disease, choose an agent that's proven to reduce major adverse cardiovascular events and mortality. The drugs currently approved by the FDA for this indication are empagliflozin, an SGLT2 inhibitor, or liraglutide, a GLP-1 receptor agonist. So we've included a coronary crown logo with each of these agents. Dipeptidyl peptidase 4, or DPP4, inhibitors are the last class of oral agents to discuss. They're represented here by these 4 dripping pieces of clothing hanging out to dry. Ominously child-sized. DPP4 inhibitors work by increasing levels of endogenous GLP-1. The available agents are sitagliptin, saxagliptin, linagliptin, and allogliptin. Not only is GLP kinda hidden in that gliptin suffix, in keeping with our clothesline theme here, when you see gliptin, just think of these gliptin clothespins. DPP4 inhibitors are generally weight neutral and do not increase the risk of hypoglycemia. DPP4 inhibitors may also be associated with acute pancreatitis and are generally avoided in patients with a history of pancreatitis. Alright, it's time to talk about insulin again. In the setting of type 2 diabetes, beta cell function declines over time and oral agents become less effective. After sufficient beta cell burnout, insulin may be required in these patients. Insulin can be added to metformin in these patients with type 2 diabetes who fail metformin monotherapy. Insulin is also the treatment of choice for patients who are still not meeting their glycemic targets on multiple oral or injectable agents. In newly diagnosed patients with type 2 diabetes and a hemoglobin A1C greater than 9 to 10%, clinicians may even consider starting insulin alongside metformin, especially if the patient is symptomatic or has particularly high blood sugars at presentation, though there isn't clear evidence supporting a specific threshold for initiating insulin therapy in the setting of type 2 diabetes. Insulin can decrease the hemoglobin A1C anywhere from 0.5 to over 2.5% depending on the intensity of the regimen. This is symbolized by the 2.5 down arrows incorporated into the fence behind our insulin scale. When insulin is started in combination with oral agents, such as metformin, it can be started with basal only, typically starting with 10 units per day, or about 0.1 to 0.2 units per kilogram per day. We've highlighted, in red, this conservative starting dosage on the scale. Also, if you look up at the egg, You'll see that the base, or basal half of the egg, is also red. This initial basal regimen usually consists of a single bedtime injection of intermediate acting insulin or a single bedtime or morning injection of long acting insulin. Basal insulin suppresses hepatic glucose production and maintains near normal glycemia in the fasting state. This type of regimen can be effective for patients with some remaining beta cell function. As beta cell function declines, patients also require boluses of short acting insulin before meals to control the glucose excursions that occur after food is absorbed. This is usually in the form of a short acting regular insulin or rapid acting insulin Lispro, Aspart, or Glulisine. This combination of bolus insulin on top of longer acting basal insulin is highly effective in achieving glycemic targets in most patients. The regimen ends up looking similar to that of a type 1 diabetic, with approximately 50% of the total daily dose in intermediate or long acting basal form and 50% in short acting bolus form. Insulin is an anabolic hormone, so weight gain is a common side effect. Weight gain is more common with more intense insulin regimens. It's not clear if this weight gain is clinically important, as insulin clearly decreases microvascular complications of type 2 diabetes, though the effect of tight glycemic control on macrovascular outcomes is less clear. Weight gain is a major cause of patient noncompliance, so make sure to caution your patient about weight gain and promote lifestyle modification to prevent it. Hypoglycemia is another common side effect, though it's less likely in patients with type 2 diabetes taking insulin compared to patients with type 1. Prandial insulin is more likely than basal insulin to precipitate hypoglycemia. In diabetics, hypoglycemia is generally defined as a blood glucose less than 70, with a lower threshold in non diabetics. And if you take a look at this unnecessarily creepy gargoyle up in the tree, you can see that we've incorporated the number 70 into his design. However, be aware that patients with chronically very high sugars may experience hypoglycemia symptoms at a higher serum glucose level. Patients with hypoglycemia may report symptoms of sympathetic neural overdrive, such as tremors, palpitations, anxiety, and diaphoresis. They may also experience cognitive impairment, which can range from mild to severe, like seizures and coma. Most episodes of hyperglycemia can be treated with consumption of fast acting carbohydrates, such as glucose tablets, hard candy, or sweetened fruit juice. In the setting of severe hypoglycemia, IM glucagon or IV dextrose may be necessary. At Sketchy, glucagon is symbolized by a sweetener packet, since glucagon is kind of like the opposite of insulin, working to raise blood glucose levels. In this scene, it's being wielded as a makeshift shield by this kid here, performing an intramuscular attack. And let his sister swinging into the scene with a dextrose remind you of IV dextrose. Alright, let's wrap up the scene with the management of diabetes in a hospitalized patient, specifically a patient admitted for a chief complaint other than DKA or HHS. First of all, order a hemoglobin A1C on admission if one has not been performed in the prior 3 months. This will give you an idea of whether their current regimen is effective. The goal in the hospital is moderate glycemic control, with a target glucose range of 140 to 180 milligrams per deciliter, and, more importantly, avoidance of hypoglycemia. There is no benefit to tight glycemic control in the short term, and the risk of hypoglycemia increases with tighter control. It is critical to avoid hypoglycemia because it's associated with poor outcomes. In most hospital settings, insulin is the preferred treatment for glycemic control because it's easily adjustable. For this reason, oral medications for type 2 diabetes are often discontinued on admission, which is why this curious kid here is discarding those oral candies as he explores the forbidden candy garden. Keep in mind that you can consider continuing a patient's home oral regimen if they're well controlled on oral medications at home and expected to be eating a normal diet. It can be difficult to predict how a patient's blood sugars will run in the hospital. Sick patients sometimes have an increased insulin requirement due to increased metabolic activity. However, inconsistent oral intake, or outright NPO status, may instead lead to a decreased insulin requirement. Patients on insulin at home, such as those with type 1 diabetes or severe type 2, can be kept on their home insulin regimen while in the hospital. However, most providers will reduce the dose of each of their injections by 25 to 50% to avoid hypoglycemia. To convey this, we've drawn in a miniature gingerbread house. Think of their home regimen, but smaller. If the patient is NPO or their expected PO intake is uncertain, Withhold their preprandial or bolus insulin injections. The basal insulin should still be given, but just at a 25 to 50% reduced dose. This is depicted by this girl here next to the do not eat sign. She's discarding the top of the egg, preserving only the basal portion. But what do you do for the patient who doesn't have an established insulin regimen? For example, the patient whose home oral anti-diabetic medications are being held while in the hospital. Well, you can start an insulin regimen by performing a weight based calculation to estimate the total daily dose of insulin, just like the calculation we discussed at the beginning of the sketch. Patients typically start with zero point 0.3 to zero point 0.6 units per kilogram per day, which you might notice is a bit higher than the initial calculation we used earlier. This is because patients with type 2 diabetes are insulin resistant, especially if obese. Opt for the lower end of this range in underweight or elderly patients, and the upper end of the range for obese patients. Now that you have the total daily insulin dose, it's time to divide it up, just like before. Approximately 50% of the total is given as intermediate or long acting basal insulin, given as a single dose or divided into 2 doses per day, and the other 50% is given as short or rapid acting preprandial bolus insulin, divided into 3 doses, such that 1 dose is given before each meal. Remember, though, to hold these preprandial doses if the patient is NPO or expected to have uncertain PO intake. You can also add on what's called a correctional scale insulin, represented by this kid here correcting the scale. This insulin is given on top of the basal bolus regimen you've set up for your patient. Typically, glucose is checked before each of 3 meals and at night. The nurse performs a fingerstick glucose at bedside, then consults the insulin correctional scale order for instructions. If the glucose level is above the specified goal, the corresponding correctional dose of short-acting insulin is administered in addition to the pre-ordered bolus dose. If the glucose level is at the goal, no insulin is given. If the patient is hypoglycemic, then juice or sugar solution is given instead. So, how do we adapt to our patient's insulin needs? It's simple. Just add up the total amount of insulin given over the past 24 hours. This includes the long-acting basal dose, the pre-meal bolus doses, and any correctional doses that were given. To remind you of this, we've put a sun on the back of this kid here standing on the sliding scale. That's 1 sun for 1 24-hour day. Once you know their total insulin requirement, the calculation is the same as usual. Divide the whole thing in half. Give 50% as basal and 50% as bolus preprandial insulin injections. Again, just going to reiterate that you need to hold the preprandial doses if the patient is NPO or expected to have uncertain PO intake. Prior to discharge from the hospital, patients previously controlled on oral medications at home should be transitioned back to their oral medications. Well, that got weird. Let's quickly recap the moral of this story. Patients with diabetes should have their hemoglobin A1C tested at the time of diagnosis and routinely as a part of continuing care to assess glycemic control.
More often.
For most patients, an A1C of less than 7% should be the goal. Lifestyle interventions, like diet and exercise, are the first step in management. Remember that in patients with long-standing type 2 diabetes, glycemic control helps prevent microvascular complications, while most randomized controlled studies have failed to demonstrate decreased macrovascular-related morbidity and mortality. Ultimately, the best way to prevent macrovascular complications is through smoking cessation, blood pressure management, lowering cholesterol, and, in many cases, helping the patient lose weight. Metformin is the first-line pharmacologic therapy for diabetes and should be initiated along with lifestyle interventions at the time of diagnosis for most patients. GI side effects are common, including nausea and diarrhea. Metformin is contraindicated in renal failure and associated with B12 deficiency. If patients do not meet their glycemic target with metformin and lifestyle interventions, then add a second agent, like a sulfonylurea. It can also be used as an initial agent in patients with contraindications to metformin. Keep in mind, sulfonylureas cause weight gain. Hypoglycemia can occur as well, especially with the long-acting agents. Pioglitazone, a TZD, is another option for a second agent or an initial agent in patients who can't take metformin or a sulfonylurea. They are not associated with hypoglycemia, but can cause weight gain. They're contraindicated in heart failure and are generally avoided in patients with low bone density or other risk factors for fractures. For patients with diabetes and established cardiovascular disease, Liraglutide and empagliflozin should receive preferential consideration as a second agent because they reduce cardiovascular morbidity and mortality in these patients. GLP-1 receptor agonists and SGLT2 inhibitors are associated with weight loss and a minimal risk of hypoglycemia. Win-win. GLP-1 receptor agonists can cause GI upset and may be associated with pancreatitis. SGLT2 inhibitors, on the other hand, cause an osmotic diuresis, which can lead to hypovolemia. They're associated with an increased risk of genitourinary infections as well. In some cases, a third oral agent or injectable anti-hyperglycemic agent can be added for patients who remain suboptimally controlled. DPP-4 inhibitors are another class of medication available. They're weight neutral and not associated with hypoglycemia. If patients are not meeting glycemic targets on multiple anti-hyperglycemic agents, then it's time to switch to insulin. Patients may only require a long-acting basal insulin in the beginning, but as beta cell function declines, they'll require bolus insulin with meals too. Insulin therapy is associated with hypoglycemia and weight gain. Warn your patient about weight gain and combat it with lifestyle modification.
I'm not perfect, but I try and watch my diet and exercise.
Are you done?
Shut up.
Moving on. The patients with diabetes in the hospital, the most important thing you can do is avoid hypoglycemia. Oral meds are often discontinued, and an insulin regimen is started. Keep in mind that you can continue their normal oral meds if they're well controlled and expected to eat normally. Patients on insulin at home can be put on their home regimen, but typically reduced by 25 to 50% to reduce the risk of hypoglycemia. Patients who are NPO should have their prandial bolus doses withheld. Patients without a home regimen can be started on a new one based on weight-based calculation. 50% of the regimen dedicated to basal insulin, the other 50% for prandial. Unless they're NPO, of course. Then hold that prandial. Patients will also be on correctional insulin. To keep up with your patient's insulin requirements, add up the basal, prandial, and correctional doses over the past 24 hours. Then do that same 50% calculation to find their new basal and bolus needs. The end. In our next sketch, we'll illustrate the chronic complications of diabetes you should be looking out for.